start off with, I would like to invite Troy Bannister up to the stage. And he is the CEO and founder of Particle Health, which is interesting on this whole big connection to have a name like Particle, which is about the finer points here. But tell us a little bit about Particle Health.
Yeah, so Particle Health, we call ourselves the Plaid of healthcare. If anyone knows Plaid, they're in the finance space. They partner with all the banks. They created a really simple API for developers. And then since then, we've seen companies emerge like Venmo, Mint, and Robinhood that wouldn't exist without Plaid because they solved the problem of fragmented banking data. So we do the same thing. We partner with EMRs and build a really simple API that just takes your first name, last name, date of birth, and zip code, and can find all your medical records within minutes. We now have access to about 250 million lives across our network.
Wow, okay. So how does it actually work? I mean, you say it's like Venmo, but maybe from a patient perspective, and then tell us about how it works with all the other entities you work with.
Yeah, so right now we're really focused on treatment use cases. So anytime a doctor or a pharmacist would need to look at your record to make a decision. But what we're working towards is anybody could go to the App Store on the Apple or Android, download an app, give permission, and we would be able to pull all your records within minutes into that application. The infrastructure is there. The consent tool we built out is there. And so what we really are looking forward to is working with small innovative companies that have new ideas that wouldn't exist without us, without access to the US healthcare system. And so we can connect them within days through our API to hit any EMR in the country.
So how do you actually sew together this vast sort of not really very well connected healthcare system that we have to actually give somebody access to all of that?
That's what we've been working on the last couple of years. There's these committee-based standards that are completely nonsensical. And they started like in the 90s, and they said, if you're going to exchange data between one hospital to another, you have to follow these rules.
Right.
Turns out no one really follows the rules. So that's a big surprise, right?
Okay, I'm shocked.
My CTO, Dan, is here somewhere, probably still banging his head against the wall, trying to solve this completely.
See the guy laughing out there?
Crying.
Yeah, crying, yes.
So we've been building this integration network for the last couple of years that is able to take data from one hospital, data from another hospital, and essentially make sense of it so that we can bring it back to the customer.
Yeah. So how does it work as a business? Like, do I as a patient or consumer pay? Or?
No.
Okay.
It's always free for the patient.
Yeah.
We want people to use this. We think it's really an interesting tool for early stage companies. So it's essentially free to start. We have a sandbox on our website with fake records, so you can just hop on and start playing around with it, create your own apps on top of it. And when you're ready, we give you a key to the API, and you can start pulling live records. We just charge per record. So if you're a small company with 20 patients, you're going to pay $20 a month. So it's really affordable to start doing this.
What about the big hospital systems, things like that?
Yeah, so we're talking with payers. We're talking with pharma groups that are looking at, like a payer that wants to do risk adjustment for like Medicare, Medicaid will say, we've got 2 million names that we want you to pull records on. They're doing it by fax today. It takes them 6 months and costs a lot of money.
Yeah.
Most of these groups we talk to do it by fax. It's about 75% of data today is moved around by fax. So we're competing against a fax machine a lot of times, which is nice. But we'll get a large list of names, millions, and at that point we do volume-based pricing. So they'll negotiate ahead of time, and we'll get it down to like 10 cents or 20 cents a name, so it's sort of a thing.
Mm-hmm. So faxes, I mean, seriously? Yeah, I mean, we all see it, right?
Yeah. There's a multi-billion-dollar company out there called Ciox Health that is an army of people that literally drive and fly around the country and fax records around. That's today.
Yeah.
That's 2020.
How many people out there, don't raise your hand, but I'm wondering how many people actually have a fax machine anymore. Although if you're in medicine, maybe you do, right?
Yeah.
Yeah, exactly.
We have to, I guess.
Yeah. So walk me through, I'm a patient, I'm going, in for maybe a outpatient procedure or something like that.
Yeah.
Or maybe a better example would be I bump my head and I'm not in my home state.
Sure.
And I need to go into an ER or something like that.
Yep.
Is this literally something I can pull out my phone and?
Well, you wouldn't have to. If we're connected to that hospital, it's just there. That's it. Where it gets kind of interesting is, let's say you have a rash or something, and you dial up a telemedicine doctor.
Yeah.
Before you even get on the video call with them, they'll have your full record. And we process it and parse it, so it's really simple to say, this person's taking these meds and have these allergies. The doctor would maybe even know ahead of time why you have that rash. So we save maybe 10 minutes from the consult time and have much more personalized care, convert the customers into coming back here because they have all your records. You can use that information for claims processing. It's like the missing key to a lot of these issues.
I mean, what resistance do you get for this? Like, I mean, systems that don't cooperate, or I mean, it's actually, I don't know. It's surprising to hear that this works. To be honest with you, I mean,
right?
knowing this is almost like the holy grail that people have been trying to do. Like, I go into my doctor and he or she actually has access to my records. I mean, that doesn't happen
all the time.
Stopping.
Yeah, I mean, we're working on it.
Yeah.
The big limitations right now are, one, the data that we get comes in somewhat different formats. You can get CCDAs of different years and versions. You can get fire bundles of different versions. So one thing that we're working on a lot right now is just getting that to like one nice packet of information that you can pick and choose from. So that's one limitation.
Yeah.
The other big limitation is the use cases that we're allowed to use the data for.
Mm-hmm.
So for a doctor to view your records, to give you care, it's ubiquitous across the board. Okay, every hospital in the country is okay sharing that data with another doctor to let you have better care. When you start moving to things like life insurance underwriting and marketing and research, it takes a very different type of process to pull that information. You need express patient permission. You need the agreements with the hospitals to identify that this use case is okay. What's interesting is with ONC right now, the national coordinator, most people here might have heard of information blocking legislation coming down the pipeline. Basically what they're saying is, if you're an EMR, you have to share data if the patient's asking for it, or else we're going to fine you a lot of money. So this year is the year that's taking root. And so there's going to be a lot of use cases that are going to be emerging over the next 6 to 12 months that will allow us to start playing in research and payers and other types of areas.
Sort of nice when those rules force people to use your product, right?
Yes. Well, right now there's not really an alternative to what we're doing. There's faxes, there's patient portals, which is like you have to go find your records. Like Apple Healthcare uses this. And then there's just direct integrations where you like partner with a hospital and do one integration to that one hospital. But with us, it's just one agreement, one integration, and we get access to every hospital in the country pretty much.
Wow. So what about the whole state-to-state issue and the different rules in different states?
We've covered that. So there are different rules in different states. I think there's one state, I think it's Michigan, that requires consent for treatment. So you'd have to get a patient permission to pull records for treatment. Other than that, everybody is pretty in line. The federal government has the HIPAA rule, and so we follow that to a T. And what's actually kind of interesting is we're actually enforcing HIPAA. The P in HIPAA doesn't stand for privacy; it stands for portability. And the rules are actually meant to allow you as a patient or consumer to access your records. That's what they're built for. But people use HIPAA as a kind of scapegoat. To block the data.
Yeah.
So when we request data from a hospital with patient permission, they legally have to give it back, but they don't a lot of the time. So that's what we're enforcing, and the government's starting to fine hospitals and EMRs now. This is the first year they started doing it in 2019. A couple $1 million for not returning records.
Interesting. Yeah, HIPAA does a lot less than people think it does, actually.
Yeah, I think it impedes more than it should. Yeah.
Yeah, and I want to talk to you more about privacy in a second, but just to finish off what you can put on the platform, could I enter like my genomic data on there, or data that's not been collected by a healthcare entity, but by a company, or molecular data, or
Totally.
I don't know, diet? I mean, how far do you go on this?
We did EMR data. We're like at critical mass with that with 250 million patients. We're starting to look at claims data.
Yeah.
We're starting to look at IoT, so Apple Health Watch and all these other things. Genomics is on the list. Social determinants of health. The idea that we are really pushing towards is, with one consent and one API, can we allow you as a consumer, we really think of this as a consumer, to share this record and this aggregated holistic information with kind of anything you want or don't want, right? You can choose. And it's instance-based, right? It's not like I'm setting my rule engine. I'm not like, I'm okay with sharing with pharma, but for non-commercial reasons, academic reasons only. It's not that like high level. It's I'm downloading an app. I know exactly what this app does. I trust this app because my friends use it, and I give this app permission. So it's very instance-based, which gives, I think, a lot more security around how you can share.
Well, let's talk about that. 'Cause,
Yeah.
the privacy. I mean, obviously, this is approaching that era, that period that we've all been thinking about, both good and bad. I mean, it's good because you have access to all this data, and the people that you want to have access to that data, physicians or whoever it is.
Right.
But also, as we know, it's very hard to protect that data from people we don't want to see.
Sure.
So how does that work? And by the way, is that a problem? And
It's not a huge problem yet because the data has just been so siloed.
Yeah.
That if a hacker group comes in, and this has happened quite a bit this last year, holds a hospital hostage and locks their data down in exchange for money, which has happened a few times last year. It is obviously a big problem ethically and everything, but that data that they pulled out isn't your entire record. It's not your entire history. It's just at one place. Mm-hmm. If we're talking about an entire holistic record going back 10 years with genomics and IoT, it starts to get a little bit more significant. And so the way we think about it is there are only some companies out there that are at a certain level of security and are certified to kind of do this. Mm-hmm. And so there's a certification process with the ONC called TEFCA and the QHINs. And so we've gone through the certification. We're headed towards high trust and SOC 2. So there are these levels of certification and validation that you can approach and get the rubber stamp on. That makes it really tough to kind of hurt that problem, have that problem really be ubiquitous.
Yeah. I mean, is this part of the architecture of building the app it must be very challenging?
Well,
I mean, some awfully big players that have a lot of money are having.
Here's an example. Yeah. For us, we delete your record after we hand it off.
Oh, okay.
We don't hold on to it. Why would we? It's just the wrong thing to do. So what happens downstream from that is a different question. But for us, we know that holding onto your records is a privilege, and should only happen if you expressly ask us to, right?
Okay. Well, where do I sign up?
Download an app that uses us.
Very, very good. Very good. Well, hey, Troy, thank you so much.
Thank you. I appreciate
really
it.
Great. Thank you.
Thank you.
Thank you.
Thanks.
Troy Bannister.